For example, we had the normal body and homeostasis that our kidneys maintain, but when you're not able to get rid of that, you're adding volume. EPO. That's what it is. There we go. That EPO. Was the nickname.
You are listening to EMS with your hosts, Erik Axene and Matt Ball.
That would be fun stuff to do.
Yes, it would. You know who wouldn't do that stuff very well?
Who?
A dialysis patient. No, seriously, you can't go backpacking.
Oh, there's no way.
You do a one-day trip potentially, but even then,
yeah,
not having kidneys, you're so limited.
Oh, yes. I mean, yeah, you couldn't be properly hydrated.
No.
You would either be dehydrated or overhydrated, right? Yeah. You're not going to be urinating. Yeah.
Yeah, you wouldn't have to stop to pee.
Yeah, you wouldn't have to stop to pee. That would be the only benefit, although it's not a big deal when you're on the trail. You just, especially as a male.
Yeah, right. Well, so the dialysis patient, that's our podcast here today, is to talk about the management of dialysis emergencies.
Yep. Yeah, and these are very common patients, whether you're 911 or, doing an IFT, you're a transport unit, BLS, ALS, you're going to see dialysis patients. Yep. Very common.
And I think a good understanding of the pathophysiology of dialysis patients, or really of kidney function, helps us to really understand all of the different emergencies we may have to follow protocols to manage.
Yeah.
And I think understanding all of how kidneys work really help to illuminate the diseases they cause.
Until we did this topic, I never really tied the congestive heart failure patient with the dialysis patient. I never really correlated the two. Yeah. But then after going through our lecture and everything, I'm like, this is the same pathophysiology.
That's right.
Different cause, but same pathophysiology. And you have either fluid overload or fluid depletion.
Yep.
You can have hypertension with pulmonary edema. You can have hypotension with weakness and lethargy. Hemorrhage, infection.
Graft malfunction, which might cause you to miss a day, and missing a day causes all the problems.
Right.
Yeah, no, it's cool, really cool to make those connections.
Yes.
When you see the connections between two disease processes, that's really cool, and the brain does that. It feels good. Those aha moments are fun. I love having those myself. I love it when the students have it. I like experiencing them with a colleague. Yeah. Those are really fun.
Yeah.
Yeah.
It's just kind of, this is kind of the same thing here.
Yeah, so let's start. So
why does somebody need dialysis? Let's start with that.
Yeah, so, and I think I'll even go back further than that. I think, what do the kidneys do? And
there you go. So functioning kidneys.
Yeah, functioning kidneys. You and I have got functioning kidneys. Today we went and grabbed some lunch. We got back, and I had to go to the bathroom because my kidneys had created some, after they filtered my blood, they created some waste products collected in my bladder, and I need to empty the bladder.
Yeah.
A dialysis patient doesn't have working kidneys.
Yep.
They cannot create, or some dialysis patients will create some urine, but
not adequate.
No, not adequate enough to really do any fluid balance or keep the electrolytes normal.
You know what we should do? We will insert from our lecture. We will insert our little beaker thing right here.
Yes. Matt, that was so cool because it was your idea, I think, that actually made that demonstration come to life.
Well, it was your idea originally.
Well, it was my idea originally to do that, to have the flasks and the beakers up and to show where the body water was, because I knew that, and now we all know, and our students will know soon, that it's not about how much fluid there is. It's really about where the fluid is in the body. Yeah. We accumulate fluid in a confined space like the intravascular space or the blood is. It doesn't do well when we get too much in there. We end up with pulmonary edema, some edema in the lower extremities. All these things cause problems.
Yep.
And but what you did, though, I thought was so cool. I had all the demonstration ready to go, but then you thought, hey, let's demonstrate what happens with a dialysis patient. And we've poured extra water into that intravascular space and overfilled it to demonstrate what happens in dialysis. Yes, that's a great idea. Let's show that, and then that visual demonstration. I thought that was so powerful.
All right, we're back from our visual demonstration.
Yes.
I think it's a good visual. I'm a very visual person, so having that visual picture really helps my brain make those connections. And that was a good one. Because like you said, normal functioning kidneys, right, we don't get volume overloaded because our kidneys do their job. They excrete what we don't need, right? Not just fluids, but also electrolytes, which we're going to talk about. And we get rid of those things, right? But in that kidney, and again, we say somebody with no kidneys, they still have kidneys, they're just not functioning properly. Or maybe they've, whatever the case may be, kidney damage. And then they get overloaded, volume overloaded, because they're not excreting that fluid. So as we showed in our example, we had the normal body and homeostasis that our kidneys maintain, but when you're not able to get rid of that, you're adding volume to that blood supply specifically, which causes the problems that you talked about earlier.
Yeah. You know, one thing we didn't talk about in our dialysis lecture that we did was the causes for kidney failure. What actually causes kidney failure? Well, it's usually, I think the most common cause would probably be diabetes or hypertension, just those comorbidities that, you know, every time your heart pumps with a high blood pressure, it's like a sucker punch to the kidney. It's like right and left, uppercut, right, left, jab. And over time, that chronic beating down with the high blood pressure can cause what's called a hypertensive nephropathy, or basically blood pressure is killing the kidneys over time. The other one is diabetes. You can get a diabetic nephropathy, where with diabetes, as we've talked about in our diabetes lectures, it hits those tiny vessels. And those tiny little vessels in the nephrons, they get munched and you lose kidney function pretty quick. You can also have congenital problems. You can even get a medication, or even an iatrogenic, or like a medication can cause kidney damage, like ibuprofen. You overdose on that, it can cause kidney damage. And even IV contrast. You get a bad contrast nephropathy, and that can even cause it. And then there are some other viral infections that can hit it, but a lot of causes for kidney problems. So if your kidneys do shut down because maybe poorly managed diabetes or hypertension, you're going to start noticing some symptoms. You're going to get swollen in your lower extremities. You're decreasing your urine output. You know, I'm not peeing very much. I'm feeling really swollen. Man, I don't normally get this short of breath walking from one room to the other in my home, right? So those are signs, potentially. Could be other things, but that's part of the symptomology of kidneys failing. And there are medications that can slow the process, but once your kidneys go,
you're not going to recover.
Unless you get a transplant, kidneys are not going to do well.
So those patients, once you're in that renal disease stage and they're not functioning all the way, there's basically two different types of dialysis that you can get. The peritoneal dialysis. Typically patients will do that at home, where it kind of comes through their peritoneum, pull the fluid off. And then you have the hemodialysis, or hemodialysis.
Hemodialysis,
where they go in, this is the more common one that we see, whether we get called out 911 or we're transporting back and forth for their dialysis, is where they're taking the blood out and doing it that way.
That's right. And that's the one we're going to cover primarily here today. There are some emergencies and complications of the peritoneal dialysis, but the hemodialysis one is really more profound and something we want to be able to cover. They're the ones that are more commonly going to call 911.
I was going to say, that's definitely the more common one we're going to see, for sure. Especially, like I said, you're doing IFTs, you're transporting these patients. I was listening to, I don't think it was a podcast really, but it was a video, again, just doing research for our lecture. And they actually interviewed a guy who I don't know if he got a kidney transplant or what his story was, but basically for a short time, he was on dialysis. And he was saying a couple of things that he said. He's like, dialysis does not make these patients feel better. It just makes them feel less worse, is what he said. He said that dialysis patients chronically feel bad. They're chronically tired, in pain. They just don't feel good because their body's not functioning properly. They're either too low, too high. They're never at homeostasis, right? So they never really feel good. Dialysis makes them feel a little less bad. He said, these patients can typically be very grumpy because especially if you're picking a patient up for dialysis in the morning to take them to their dialysis. They're tired. They're grumpy. Their diet is very bland, low salt, not a lot of flavor. What he said was, he goes, let me explain the dialysis diet to you. He said, if it tastes good, spit it out. He's like, basically, and he goes, so that, just emotionally, that makes you miserable. You can't enjoy any food, and then you've got this you got to go into dialysis every day, and that takes hours, and you're dealing with shunts and these other things. Not a fun way to live.
And a lot of the things that you may have enjoyed doing, you can't do them anymore as easily anyway.
Like climbing the Manitou Incline.
That's right.
Although people might say that we're psychos for trying to do that. But yeah, I mean, like just day-to-day life is dramatically impacted because these patients are typically going in 2 to 3 times a week, if not more.
Yeah.
And it takes time. It's not a quick procedure. They're there for several hours.
And when we see them, it's typically because something went wrong on top of their kind of arduous, regimented life of dialysis 3 times a week.
Right.
Their shunt is not working.
Right.
They missed the session. They had to call 911. And so it's almost just heaping, it's like out of the frying pan into the fire.
We were talking to a friend who had a family member that would do dialysis, and he said a typical time to call would be Sunday night because they would do their dialysis on like Thursday or Friday, and then the weekend would come. Obviously, they're not getting dialyzed over the weekend, and by Sunday night, they were starting to get volume overloaded, starting to feel crappy. That's when they would have to go into the hospital, right? So again, think about all these things in context. Those could be the times you're getting that 911 call for that patient. And anyway, we can continue on with some signs and symptoms later on what you might see in that volume overloaded patient.
Well, you said it right there. One of the first functions of the kidney that we would lose, obviously, would be the ability to be able to manage the fluid volumes in the body. So the kidneys are really good at getting rid of fluid if we've got a little too much or holding on to it if we need more. When you lose that kidney function, you become at risk for volume problems.
And electrolyte problems.
Problems. So let's talk about the volume problem. So if you are volume overloaded because your kidneys are not able to get rid of extra fluid like you used to be able to, and now you're dependent upon the dialysis center to remove the extra fluid, how would that patient present?
Again, this is where I see the correlation between that volume overloaded dialysis patient and a congestive heart failure patient. You've got too much volume, right? That fluid has to go somewhere, right? And so it's going to be excreted, right? It's going to end up in the lower extremities. You get that peripheral edema, and then it starts to back up into the lungs. You get that pulmonary edema. That increases that space for gas exchange. They're going to have shortness of breath. Again, you may or may not see that peripheral edema. You might hear crackles on lung sounds. Those are typically the presentations you're going to see in these patients.
That's right. And in addition to that, I would say too, is that not only are you volume overloaded, which creates the problems you mentioned in the lungs and the lower extremities, it's really everywhere. But with too much blood in the intravascular space, you got too much blood in the heart. You're actually going to be increasing the force of contractility because of Starling's forces, and now the blood pressure is going up higher, which increases this thing called hydrostatic pressure, which is what's going to drive some of the blood out of the blood vessels and make that pulmonary edema even worse. That's why when I see dialysis patients in the ER, did I just say dialysis?
Dialysis patients.
These dialysis patients that we see in the ER.
Your Marshall Bill impression. Let me tell you something.
But in the ER, when they come in, they look so bad. They look really bad.
But you dialyze them. They, again,
discharging them that
they
day.
Don't feel good. They feel less worse, right? They don't feel as bad.
I actually talked to one of my nephrologists. The typical pattern is that they'll be admitted and they leave against medical advice after they get dialyzed because they know.
It's kind of like the seizure patient that I don't need to go to the hospital. I just didn't take my meds today. I just need to be dialyzed. I know I skipped a treatment. I didn't go in on Friday. I just need to go in and get it done.
And they're not going to wait for the discharge paperwork. They've been there already 3 times in the last month. So those are tough patients, but they look sick, and a lot of this volume overload creates a lot of those symptoms that we would see, the shortness of breath and the chest pain. These things are because of volume overload with cardiac strain, and I would say that's maybe one of the most obvious, or the biggest, well, not the most obvious, but one of the bigger problems with dialysis, not having kidney function, volume problems.
And this is, you talked about chest pain, and we talked about this in our lecture. This is why it's important not to anchor. We did a podcast over confirmation bias, and anchoring is one of those things.
Big problem.
Got to keep a wide differential. You get called out to an older male complaining of chest pain and shortness of breath. Most first responders are going to go to heart attack. And rightfully so, right?
Get that EKG.
Yes, that could be the most acute thing that we need to be worried about. Are they having an MI? Do we need to get them to a cath lab? But we need to keep a wide differential and say, wait a minute, I need to show up. Maybe this is a dialysis patient that has missed some treatments and their potassium has gotten too high. Their volume overloaded.
Yeah.
Now they're having chest pain and shortness of breath because of the volume overload, not because of a STEMI or because of an obstruction. And we do that EKG, and it's important. Watch our lecture to learn about the peak T waves, but can look very much like a STEMI, especially to maybe a newer paramedic. They might be thinking, oh my goodness, this guy's having a STEMI. He's got these big T waves, this ST segment elevation. And they take him to a cath lab and they activate, and the doctor's like, he hasn't been dialyzed in 4 days. He just needs to be dialyzed. We don't need a cath lab. Yeah. So...
yeah, I got to take care of those expected sources before we jump to some of the less common.
But that's where doing a good assessment and asking your patient
Get the context.
questions.
Use the word context.
When did this start? Well, and typically a patient that gets dialysis is going to tell you that. Oh yeah, I haven't been dialyzed. I needed to go in on whatever, Thursday and now it's Tuesday. Oh, okay. Now we're shifting, right? Because context is very important. Now we're not taking STEMI off because they could still be having a STEMI, but now we're thinking, now we're kind of STEMI and hyperkalemia are kind of right in the same line there.
And the progression that you'll see on the EKG, the first thing you'll see with as you increase your potassium level, well, actually, you could potentially see hypokalemia if they took off too much, and then you get that U wave after the T wave.
Right.
But when you start to see potassiums up over 6, you're going to see those peak T waves. They look like a church steeple, narrow base, symmetric, exactly. Yeah. Whereas the hyperacute T wave of an early MI would be more of a wide base and less symmetrical.
Right.
But then as you continue to increase, then you're going to start to widen that QRS and lengthen the PR interval. Yeah. That's now a sign of maybe getting over 7.
Yeah.
You get up near 9, you're gonna lose the P wave completely, and you're going to get into that sinusoidal pattern. Right. And I think we talked about this quite a bit in our lecture. So if you want some more details on that, if you're watching or listening to this one, check out that other lecture. We go into some detail.
And a lot more graphics to actually show you what the EKGs look like.
Yeah, and the light board too.
Yes, light board, yep.
Maybe we could just throw up a slide real quick just comparing the wide-based T wave of an early MI to the narrow-based symmetric church steeple form.
And how it looks like it's being pulled up.
I love that.
Like somebody's grabbing that T wave and pulling it up. It gets narrower as it gets taller, right? As opposed to, like you said, that ST segment, that widening of that T wave before they get that actual STEMI.
So you're dealing with some pretty high potassium when you're getting to that sinusoidal, wide, complex rhythm with usually bradycardic. Yep. It's a wide and slow. It's
they're
really
not
weird.
perfusing well.
Yeah, they're going to probably be looking very sick, and you're likely intubating them.
Probably going to be putting the pads on. Probably going to be intubating. Nothing we can do in pre-hospital is going to lower their serum potassium levels. No. All we're going to do is be putting Band-Aids, calcium. Shifting things around. Calcium's going to protect that myocardium.
Yeah, it was good. I'm glad you said that because follow your protocols because the calcium can actually do some good. I've seen it happen. Yeah. Just going from a sinusoidal pattern to a normal pattern just with the calcium. Yeah. It does do some crazy things with the myocardium in protecting it.
Albuterol. It's another good option.
And to your point, though, it does not get rid of the potassium. No. It's just shifting it into another fluid compartment, a different beaker, right? So it's
just buying you some time, or I should say buying the patient some time to get them to the facility so that they can controllably reduce that potassium.
Yep. Yeah. Yep. So another problem too with and we talked about the high volume and we kind of touched on the potassium, but it's not just potassium, it's all these electrolytes. Mm-hmm. The kidney is so important in managing electrolyte balance in the body.
Sodium, calcium, potassium. Yep.
So because that's such a vital function of the kidney, when we don't have kidney function, now we've got to go to the dialysis center, not just for volume, but also for electrolytes. They have the kind of the master sort of the perfect proportion of electrolytes, run the blood through it, and it corrects them while they're managing volume. Yep. And then the patient leaves the dialysis center with a normal sort of an electrolyte profile.
Somewhat, yeah.
And unfortunately, just like we talked about with volume, over the next couple of days, you're going to accumulate volume.
Yep.
Your electrolytes are going to get a little out of whack. You got to go back into I like to call it the kidney center and become a kidney for a little while.
Yep.
But then for the next couple of days, you're not going to have kidneys again. So that's why they have to keep coming back consistently. Yeah. And that's actually why in our lecture we talked about the physiology, tightrope physiology.
Yeah.
Right?
Yeah, it's a balancing act.
It's a balancing act.
Total balancing act. And that's what our kidneys are doing constantly. I think another good slide that we talked about was how active the kidneys are.
Oh, that's a big
1,800 liters, right?
We should have started with that. That's right. Yeah, 1,800 liters a day of blood to those kidneys. Fill up a normal size hot tub. Yeah,
two.
Yeah, 2 times.
Yeah, or twice, yeah.
Yeah, twice, yeah. And then of the 1,800 liters of blood that are going to the kidneys, about 180 liters, that's 92-liter bottles of filtrate it creates in the kidney, which the vast majority of it gets reabsorbed and all the waste taken off and excreted through the ureter down into the bladder for us to, pee it out later.
Yep.
So that's an amazing function. And if we don't have functioning kidneys, I mean, what a vital function. Hey, I read something interesting. I wish I would have said this earlier, but I'll say it now.
Say it now.
So the medulla, there's 2 parts of a kidney. You got the cortex and the medulla, or medulla, whatever you want to call it.
Medulla oblongata.
Now, that's in the brain, but yes, that's the same word, though.
Mama was wrong. No, you wrong, Colonel Sanders. Little Waterboy reference there.
I love that's a funny
Sanders,
movie.
Classic.
Anyway, so the medulla, though, about 0.5% of your body mass is your kidney, 0.5. But it actually uses 10% of all of your oxygen.
Oh, really?
But it only weighs 0.5% of your body mass.
Just shows you how metabolically active they are.
Exactly what you said, yeah. And it's just another. There are so many interesting statistics. One that I like to share. Well, actually, we shared it when we spoke at the Gladney. We talked about fat cells. They burn about 4 kilocalories of energy per kilogram body mass per day. Muscle was 15. Liver, I think, was 40. And then the brain cells, nerve cells, spinal cord cells, about 240. Wow, I mean
that's a lot.
That's a lot compared to 15 in a muscle, which you'd think would be pretty active.
You would think.
To 240. Well, that's nothing compared to the kidney. They're up at over 400. Yeah. Kilocalories per kilogram per day of energy. That's a lot of energy. And that's why they need all this oxygen. They need the blood constantly. That's why they need almost 2,000 liters of blood per day.
The other thing we didn't talk about at the beginning, we probably should have, was the kidney's impact on red blood cells.
Yes.
Yeah. And
remember the name of the hormone?
The hormone?
I want to hear you say it.
EPO. That's what it is.
There we go.
That was the nickname for it. Yeah,
that's what Lance Armstrong took to increase his blood count.
Increased his red blood cell count so he could carry more oxygen, be a more efficient machine, especially doing these high elevation things, right? Got a lot more trains carrying a lot more oxygen. Some of my friends will know where that came from, but
that's good.
But explain kind of the process there.
Yes.
When we get hypoxic, it triggers. Let me see if I get it right, because I didn't know this.
Yeah, go for it.
We get hypoxic, right? We get low oxygen levels. That triggers our kidneys to tell our bones to create more erythropoietin. EPO. EPO is what tells them to do that.
Kidneys make it.
The kidneys make it. Okay, that's...
Kidneys sense the hypoxia.
A&P
It's actually what they're sensing is the low partial pressure of oxygen, right? So they sense they're not getting the oxygen they need.
Yeah.
And so
the kidneys aren't.
The blood doesn't have it. So
the blood doesn't have it, so the kidneys pick up on it.
Yeah, so you fly to Denver, you move to Denver.
Yeah.
You're now at a mile high, right? Now your partial pressure of oxygen's down from what you were used to living in San Francisco.
21% is,
So now because the partial pressure of oxygen's lower at elevation, now you're dealing with essentially hypoxia, less oxygen.
Right.
And so your body senses that, releases epoetin from the kidney.
There it is.
It stimulates the bones to make more red blood cells. That's oftentimes why folks will train at elevation, the Olympic Training Center.
To help their bodies naturally do that.
Exactly.
Yeah.
And so train at elevation, your blood count goes up, and it's a natural performance enhancer because you said it, you increase your oxygen carrying capacity, and you're going to compete down at elevation. You're going to have a more efficient higher VO2 max, all that stuff. So anyway, all that to say, the process, hypoxia for whatever reason, the kidneys will sense that, release epoetin, erythropoietin, or EPO, and then that stimulates the bones to create the bone marrow, really, the bone marrow to create and create more red blood cells. And I think we read the stat. It was like 200 times 10 to the sixth. It's basically something 2 with a whole bunch of zeros behind it of red blood cells every day. It's a pretty powerful hormone, EPO. So that's a huge function of the kidney that you reminded me of. That
just reminds you just how important the kidneys are. You know, a lot of times, especially as like pre-hospital providers, we learn a little bit about the kidneys, but not that much. And how much of an impact that on the whole body system the kidneys have, on the heart, on your circulation, on your oxygen carrying capacity, all of these things, right? You don't really think about that like, wow, if my kidneys go out of whack, it causes a systemic problem.
Huge problem.
And that's what we talked about with these dialysis patients, is that if they miss too many dialysis, this can be a cascade of failures to really lead these patients down a bad road. And we get in the city that I work in, we had a dialysis center, and we would get called there quite frequently. And a lot of times we'd go there for cardiac arrests. And, you know, we'd get there and maybe they just finished being dialyzed, or maybe they hadn't and they showed up and they were just too far down the curb and they ended up coding. But these can be sick patients, and it's really, this is one of those things that's good to understand how these things work, because then it's easier to understand how to fix it or how to help it. But,
well, so we've talked about volume management, the fluid compartments and maintaining fluid balance. It's a huge thing that the kidneys do. If you're volume overloaded, they sense that and you pee more. Your volume depleted, they sense that and they hold on to more and you pee less. We talked about the erythropoietin. We talked about potassium balance, electrolyte balance.
We didn't talk too much about the hypovolemia.
No,
so typically when the patients that we've talked about a lot, they miss their dialysis, they become volume overloaded. When patients have had their dialysis, they typically might, if they took a little bit too much off, might be a little bit hypovolemic. They might have a high heart rate. They might have a low blood pressure. They might be feeling weak or even be altered, right? And so we need to be paying attention to those kind of patients. And again, keep a wide differential, because we could also be dealing with an infection, right? So we could be just thinking, there's so many different ways. We got to keep it wide. We got to look at their temperature, make sure you don't miss things. If they have a dialysis fistula or something, look at that. Make sure it's not infection, because that's another huge risk for these patients.
Huge risk one.
But they can be hypovolemic if they get too much pulled off.
I'm glad you said that, because we have to, and when we talk about hemorrhage, we'll touch it again, but by keeping your eyes open, not all dialysis patients are hypervolemic.
Correct.
You're right. Sometimes we need some fluids, and giving IV fluids to a dialysis patient,
cautiously.
Yeah, you better have a pretty good reason, because they're so often volume overloaded. We don't want to make it worse. You know, the other thing the kidney does we haven't talked about yet is blood pressure management. So the
renin-angiotensin.
That's right. The whole there's I called it the RAS system, but aldosterone, angiotensin, all the sorts of different hormones, and how blood pressure medicines work. Some of them. That's right. ACE inhibitors and things like that. But the kidneys are essential. One of the essential ways of managing blood pressure in the body. We don't talk about it a lot when we talk about autonomic things. Like we talk about how the autonomic nervous system causes pupils to dilate and constrict.
Heart rate to increase. Respiratory rate to increase.
But the other thing is with the kidneys and managing blood pressure. If your kidneys sense a low perfusing state or a low blood pressure, they will go crazy with that renin-angiotensin aldosterone system that we've mentioned. and it will increase our blood pressure because the kidneys know, because they're so metabolically active, we need to keep the blood flowing.
Yeah.
And if we sense hypertension, we don't want to beat our kidneys up like we talked about too.
Right.
They'll do everything they can to decrease the blood pressure. Yeah. So when you don't have kidneys now, obviously,
can't have control over
you're going to have trouble managing your blood pressure. So I have seen some of the most extreme blood pressures in dialysis.
You said you saw one over 300?
Over 300. Systolic.
Wow.
Yeah, really high blood pressure. And a lot of these patients really didn't look that bad.
How are you bringing that down?
Well, when they get up that high, they're going up to the ICU on a nicardipine drip or whatever it is. I don't know. I talked to my intensivist.
Are you emergently, like labetalol? Are you giving them something emergently to try to get it down over?
Yeah, we'll give them aliquots of an antihypertensive in the ER while we get something set up.
Just curious.
You got to be careful too.
That's what I was wondering. What, like pre-hospitally?
You don't want to lower too fast.
Exactly.
Because the brain auto-regulates, and there are a lot of different things, and you will go down a certain percentage. So even at a certain point, you want to get down more, maybe percentage-wise, when it's that high.
Right.
But typically, when you're trying to lower blood pressure with a hypertensive emergency, you want to be very careful not to get it right to normal. There's a certain path we should take. It's kind of like gradual decrease.
Kind of like that hemorrhagic stroke patient, right?
Yeah.
You don't want them to be 120/80 because they won't have enough pressure to perfuse. So
that's exactly right.
Again, just kind of an interesting thought but 300, that would be crazy to see.
Yeah, it's a high. Don't see that very often. But those are the main things that the kidney does, that we've talked about anyway, functions of the kidney. And when you're in, dialysis patients, we call it end-stage renal disease. These are people with non-functioning kidneys. They've got kidneys, but they're just not functioning.
Would you call them raisins?
Raisins. I imagine when I think about my dialysis patients' kidneys, I just imagine like a prune or a raisin,
like just
where normally they look like a kidney bean or a whatever. Yeah. That's what I imagine.
I said nephrotic. I meant necrotic.
Necrotic. Well, nephrotic.
I guess it kind of fits, doesn't it?
Well, a nephrotic syndrome is a kidney problem.
Yes.
No, that's good. So we've talked about the functions of the kidney and how that can affect patients without kidneys because they don't have those functions. Right. I think the one other thing I think I might mention, we didn't really talk about it a lot, was the anemia. Because these dialysis patients don't have the kidney to release the erythropoietin, the EPO. They end up being anemic, and oftentimes will need transfusions, or they'll need a medication to stimulate the bone marrow to make the red blood cells. These patients can be very susceptible to a hemorrhagic emergency. They cut their arm or damage a graft or whatever, and they bleed like crazy. Well, when they're anemic as they can be, they're on a razor's edge, a tightrope.
Yeah,
exactly.
Yeah, they can't lose as much as you and I can and still maintain.
That's right.
They have a lot less to lose. Their tank is half full, maybe.
Yeah. And I would say, actually, you're right. I mean, because they can't control the volume level very well. But in addition to that, a patient could have a very low hemoglobin and have a full tank, but it's just really dilute.
Right, exactly.
And so when you lose a significant portion of a dilute tank, you really are really minimizing your oxygen carrying capacity of the blood, and they're gonna need help, and they're gonna crump faster than you and I, like you said. Right. So I think that covers pretty much most of the
kind of the patho
emergencies there. Let's now talk about some of the different buckets. We mentioned trauma and how susceptible they are because of their anemia. But let's talk a little bit about the graft itself, because that presents a very unique patient population with a non-normal. It's not normal to have shunting of blood like this. The average person does have some AV kind of fistula shunting in their bodies, usually a small percentage of their circulation. But an intentional graft in the arm, connecting the arteries and the veins and grafting them together creates a massive mixing of blood. You feel that thrill. You hear the bruit. You damage that with a fall and you cut that open, you're going to bleed fast.
Yes. Yeah, you're bleeding both arterially and venously. The blood you might not initially think is arterial bleeding because it's not that bright red oxygenated blood.
It actually is. Yeah.
Huh?
Oh, you're right. Yeah, it doesn't look like it.
Yeah, it's not going to look that way.
Yeah.
But you're going to see a lot of blood, right?
A lot of blood.
And so, pressure, if they've truly torn it, like we talked about in the lecture, pressure might not be enough, probably not going to be enough.
Yeah.
You may need a tourniquet on these patients.
Yep.
So...
And I've talked to my vascular surgeons about this. I actually should have talked about this in the lecture. It's like, some people are concerned sometimes of putting a tourniquet on an arm with a fist.
Yeah, because we're told
a fistula.
Don't do a blood pressure on that arm, right?
Yeah, be careful, right?
Yeah.
So throwing a tourniquet on the arm, there may be some hesitation because it's not normal. So we don't normally see that, But I talked to the vascular surgeon at our hospital about this very thing. It was a long time ago. And he basically said, don't worry about that.
Yeah. They're bleeding out.
I could fix anything you break.
Yeah,
It's like
exactly.
We could put in a temporary dialysis catheter for them while we fix it and while it repairs and matures or whatever they need to do.
It's kind of like doing CPR. Everybody, when I do CPR classes, they're like, well, I'm worried about breaking ribs. And it's like, their heart's not beating. They can live with broken ribs. They can't live with a stopped heart. So we can fix that later. Yeah. It's the same theory, right? Theory. This is worse than that. You got to sacrifice one for the other.
I've had some very, very serious patients, trauma patients, and we need a CT with contrast.
Yeah.
And we can't get any information. We don't know if they're allergic. We don't know what their kidney status is. Yeah. And we got to get them quick, right? And sometimes getting somebody to survive to dialysis is a victory.
Yeah.
We got them. They didn't die. They're in the ICU. They needed dialysis for a period of time. But you know what? They lived.
Yes.
And hopefully they won't need it their whole life. But
right.
there are certain risks and there's certain risk-benefit things we got to weigh.
Tightrope.
So, yeah. So if they needed to have a repair because of a tourniquet damaging some blood vessels somehow, I'm not even sure that would really happen.
Yeah.
Or if something clots off because it's not circulating, we can fix that later. And that's the name of the game.
You have a live patient to work on.
Yeah, exactly.
So you have to stop the bleeding. So bleeding is a big risk with these
tourniquets,
patients. Yep. Get a tourniquet on these patients. Sepsis, infection at those sites.
Yes, thank you.
Is another huge risk. High risk for infection. Again, you get called out to that patient at the nursing home who's altered, maybe had a syncopal episode. You show up, heart rate's a little bit elevated, blood pressure's a little bit low. They say she's just not acting right. They tell you, oh, she just had dialysis this morning, and you're thinking, oh, she's just a little hypovolemic. She'll be fine, right? Yeah. And you're completely missing because you didn't do a proper assessment.
Didn't get that temperature because you were so focused on what you had decided, the confirmation
bias. Yes, exactly. You thought, oh, I took a lecture from Axene and I know they're just hypovolemic. We just need to give them some time. It'll build back up their volume. And like you say, you missed that they have a fever. Yep. You missed that they have an infected site. It's red, it's puffy, it's swollen, it's leaking fluid, right? Like, you didn't do a good assessment. And you realize, oh, wait a minute, this guy's septic, this lady's septic. Oh, we need to be treating this as a sepsis, they had too much fluid pulled off.
You said it, confirmation bias. Yep. We get so stuck on the fact that this is a dialysis patient. This then must be a dialysis problem.
Yes.
Well, dialysis patients can have traumas. Dialysis patients can have strokes, heart attacks, sepsis. Yep. The hard part with a dialysis patient is they live volume overloaded.
Yes.
So sometimes we may miss the fact that they're actually hypovolemic because of sepsis. They've been losing all sorts of fluids with the fever and the who knows what, but they may not be peeing it out, but they are so dehydrated. Yeah. They actually may need fluid more, if not more than the average sepsis patient. So anyway.
Being fluid overloaded, right? You're judiciously giving them fluids, cautiously giving them fluids, watching their respiratory rate, listening to breath sounds, watching their SATs. One of the things that we have in our protocols is that if you have to, again, tightrope, you've got to manage, well, they need fluid, they need some volume, right? But they also need oxygen. So CPAP is a good option for these patients.
Great. Yeah.
Put some CPAP on these patients while you're giving some judicious fluids. You're not just dumping them to them like a normal septic patient. Yeah. But that CPAP can help push for that gas exchange through that fluid until you obviously get them to more definitive care.
Yeah, that's smart. So if you are going to give fluids, be judicious, be cautious.
Watch your sats, listen to breath sounds, trend your patients,
Right.
all those kind of things. And you should do that with that hyperkalemic patient too.
Yeah.
That you're, what's their, are they going from a peak T wave to a widening QRS? Look at the top of your EKG. What was your QRS in the first EKG compared to now? Has it gotten bigger?
Yeah.
It's starting to widen. Now my potassium is probably around 7 now that we're starting to widen. Again, maybe put a set of pads on that patient. They could code on you. If they're super altered, like you said, innovate them.
And whether you're a BLS or ALS provider, there are always things that you can do.
Yes.
And that's important to remember.
Yes.
Don't lay them flat. Let them sit up. Usually.
Yeah, just like your CHFers.
Yeah.
Keep them sitting upright. Sitting upright. Again, oxygen supplementation. CPAP's a great tool.
Yeah.
But yeah, infection. Don't miss infection on these patients. Don't miss sepsis on these patients.
I think that was a big part of our lecture because it's such a ripe opportunity to have some cognitive bias to anchor or have confirmation bias on a dialysis patient. Keep your blinders off. Keep your differential open.
Yeah.
I like that first case that we actually practiced with our lecture. We had that, I think it was a 60-year-old guy.
So. Yep.
And he's clearly the story was he'd missed a couple dialysis sessions. He was very hypertensive.
Yep.
Everything else looked pretty good on the vitals, a little bit hypoxic, I think.
Yeah, he's 92, I think, on Romer is what it was. Yep.
And so we taught.
Blood pressure was a little elevated.
Yes.
Not crazy, but 210-ish, I think.
Yeah, not too bad. But we talked through that, and I remember thinking as we were going over the case how important it is to get a good history. Because when you're called, dispatched, it's going to be for shortness of breath.
Yeah. They're not going to say, he's got hyperkalemia. It's not going to be in the dispatch notes.
No. So you got shortness of breath, and the guy that missed dialysis because you got that history, you missed 2 sessions. Now it's starting to shape your management.
Picture's starting to become clearer.
Yeah, and then you get that EKG, looking for the peak T waves. Sure enough, look at that. Narrow-based, symmetric, church steeple-shaped.
Remember, he was complaining of chest pain, too.
He was.
Yeah,
cardiac.
shortness of breath and chest pain. So, again, you might get that call for chest pain or shortness of breath. You're thinking, ooh, STEMI, cardiac.
Yep. And these people typically don't have the healthiest of hearts.
Right.
So they could get cardiac strain that's overwhelming that actually induces a cardiac strain cardiac event, causing ischemia just because the heart can't work that hard.
Right.
And it's pumping at such a pressure. Oh man, we could do a whole thing on afterload.
Trying to overcome the systemic vascular resistance.
That's right.
Yep. And it's like you said, it's already sick. You got a sick pump trying to overcome this high pressure.
It's a problem.
It's a big problem.
Yeah.
Big problem.
And I think our second case, we went away from the obvious missed dialysis session to somebody that was actually septic.
Well, I think to back up to that first case, we talked about it in the lecture, was you could get really sidetracked of this is a STEMI. If you don't do a proper history, if you don't keep your differential open. And even if, you run that 12 lead and you see those PT waves and maybe you're a newer provider and you're thinking this is elevation. Context is so important, right? Look at the whole picture. This is a dialysis patient. He tells you he's missed some dialysis sessions, right? I'm leaning more automatically towards hyper K in that situation, even though he's complaining of chest pain.
Still covering your bases.
Still covering my bases by doing the 12 lead, right? But again, I'm thinking more calcium in this guy, right? Albuterol. Albuterol is going to help. He's got low oxygen saturations, so we get a dual benefit of that. So I'm kind of leaning more towards that treatment than nitro and, pain management and transferring him to a STEMI facility. And again, you can always, these are complicated patients. Call your medical directors, transfer the 12 lead to them. Say, hey, this is what I got. I think this might be hyper K, but I'm not sure. I don't want to give him calcium and he really needs nitro. What do you think, doc? And get some help if that's okay.
And document the heck out of it.
Well, you should do that anyway.
Always.
Yes.
Didn't document it, didn't do it.
Yes.
Yeah, so anyway, good. So I think keeping your eyes open, keep the differential open.
And the second one, same thing.
Yeah, that's right, because there's a dialysis patient again.
Yep.
Don't fall prey to confirmation bias.
That's right.
right? So this lady nursing home just had dialysis, was a little hypotensive. Well, clearly it was from the fact that she just had dialysis. Matt told me in the lecture it was probably because they took off too much fluid.
Mike dropped it. I'm a paramedic. I got this.
So we'll just anchor on that, and then when this other new information comes, we disregard it because we've already made up our mind.
She feels hot. Nah, she's fine. She's just in blankets.
But you measure the temperature. She's almost 102.
Yeah.
And you get those vitals. Oh, wow. She's positive shock index.
Yes.
She's altered.
Her end title's
less than 25.
Yeah, she's
anyway,
shocky.
she's in septic shock. This is the worst kind of shock.
Yes.
So don't continue. Don't be too quick, right? To get that diagnosis.
And even though this patient is hypotensive, and in a typical sepsis patient that doesn't have a kidney problem, we would be giving them quite a bit of fluid, right? We're not going to do that with this patient. We're going to, give her a 250 bolus, see how she does. Use your pressors, right, to get that pressure up if you need to, right?
Pre-hospital antibiotics, maybe.
Yep. Yeah. If that's in your protocols, absolutely. Pre-hospital antibiotics should help out a lot here. Yep. But I think the big take home there is that, we think sepsis, fluids. Well, hang on a second. This is a dialysis patient. This is a kidney patient. Yeah. They can't flush that off.
No.
So let's maybe just give that a little bit more cautiously than we would the standard septic patient. We need to get them stabilized, but let's not get crazy with it.
And there's a lot of evidence coming out, even in a normal patient, we're not giving as much fluid as we used to give. Yeah. We're going to be doing pressors earlier now.
Per kilo is,
Yeah. So that's good. And then the very last patient, I think the scariest of all of them.
Oh, really? You thought that was the
I think so. I've seen
fall guy?
A guy falls and ripped open his AV fistula and bleeding all over the place.
Yeah.
I've seen these come in. They're usually the ones in the middle of the night, family banging on the ambulance doors, and they got him in a wheelchair with a bath towel around his arm.
Blood everywhere.
Everywhere, soaking. You can't stop the bleeding like that. Yeah. Or a makeshift tourniquet with a belt. Those never work.
Or you get called out to the hemorrhage.
Yeah, that's
you
right.
show up at the house.
That's right.
And you walk in, and it looks like somebody slaughtered a pig in there, and you're like, what is going on?
Get that tourniquet, Matt.
Yes.
Let's go.
Yeah.
Pressure first.
Yeah, exactly. Pressure first. But the treatment's the same, right? If somebody had a massive laceration of their arm, you put pressure on it, put a tourniquet on it. Yeah. It's the same thing. They're bleeding out. Yeah. And remember, these patients have less reserves, right? They're already anemic. So we got to stop it even quicker.
And I think the big take-home point for that, and for sepsis too, is to remember the profile of a shock patient, a patient that's in hypovolemic shock secondary to a distributive shock like sepsis, or potentially a hemorrhagic shock like a bleeding AV fistula. Being able to recognize the pattern of those vital signs that would indicate a potential transfusion of some blood products or whatever it might be, that's super important, and it fits into all sorts of other patient scenarios, not just the dialysis patient.
That's right. Trauma patients. Yeah. And so, again, we know that the heart rate's the pump's going to speed up first, right, to try to maintain pressure, right? But now we got a high heart rate and our blood pressure is not maintaining, right? So now we're getting into decompensated shock. Yep. Compensated shock would be the heart rate's a little bit elevated and the blood pressure's still good. Okay, we're compensating well, right? Kids do that very well, and then they fall off the ledge, right? Adults, we know, is a little bit slower. But you have your shock index, your heart rate divided by your systolic blood pressure. That number's over 1, which I think in our scenario is about 1.4. That's a pretty significant shock index, right? When a patient's in shock, let's talk about end tidal for a minute. Septic shock, hemorrhagic shock, that end tidal is going to be low because they're in a shock state, right? And sometimes we think, it's a ventilation problem. We got to be slowing down their respirations to build their end tidal back up. No, you need to get their blood pressure better. Get them some pressors, get them some fluids, get them blood if that's indicated for the patient. Get those things on board, improve the blood pressure. The end tidal will then improve as well. It's not a ventilation problem. It is a volume hypovolemia problem.
Yep, that's right. Yeah. What as we close this lecture out, what to you was the most important take-home point for anyone listening or watching this podcast?
I just think, you're going to get called out to these patients a lot. I think understanding how it works, what dialysis does, what is happening within these patients' body is very important. And I think not putting the blinders on, because this can be, you're not going to get called out typically to a dialysis problem or a kidney problem.
Unless you're called to the clinic or something.
Yeah, if you're called to the clinic, but you're going to be called out for a syncopal episode, an unconscious person, a shortness of breath, a chest pain, a hemorrhage call. And you're not going to be thinking dialysis patient, right? Yeah. So having that, anytime you get any one of those calls as a differential and doing a good assessment on your patient, asking good questions. Hey, and I mean, you can look and see, do they have a shunt? Do they have a fistula? Do they have a graft? Do they have a dialysis port somewhere, right? Asking them. If the patient is awake and alert, they're going to be the experts. Hey, your fistula here, that looks really red and inflamed, and is that normal? That looks really swollen to me, but I don't know. Oh yeah, no, that's not normal, and it's really painful. It's hurt. Oh, it's hot to touch, right? Oh, we're dealing with an infection here, right? Yeah, so use your patients as a reference. Do a very good full history, and you won't miss those obvious signs and then look stupid when you get at the hospital thinking it's this and it's really not that.
Yeah. Well, that was actually probably going to be what I would say is the take-home point, is keeping your eyes open for all of the different things that could be outside of dialysis problem. I guess I would also say that with the dialysis patient, understanding how our kidneys work
for sure
is important. To understand what happens when they don't work. Yeah, I think that's an important thing. That'll help you to remember the potassium electrolyte issues. It'll help you remember the volume problems. Oh, that's why they have pulmonary edema. Yeah. Okay, that's why I don't give IV fluids so quickly to a dialysis patient.
Right.
That to me, I think I agree with you. One of the bigger take-home points with this.
Let's talk about the Krebs cycle in the next podcast.
Well, actually, I think I want to tell you one thing we haven't talked about at all.
What?
Is you and I have healthy kidneys.
Yeah.
And I hope if you're watching or listening to this, you have healthy kidneys too.
Yes.
But I think one of the things that we miss in medicine is preventative medicine. How do we keep our kidneys healthy?
Yeah, that's good.
I'm doing it right now, drinking water.
Yep.
Make sure you drink plenty of water.
Yes, hydration.
Don't drink too much, that could kill you.
Yes.
That's like everything, right?
That's a lot. You got to drink. But yeah, it could, which is crazy. But yeah. Staying hydrated.
Yep, staying hydrated. If you are going to be exerting yourself, don't get to the point of rhabdo. And be pushing it so hard and dehydrated in an extreme environment.
And it's not just water. Hydrated. When you're out working, you're losing sodium, you're losing potassium. It's electrolytes that you're using. That's why drinks like Gatorade, which I'm not necessarily saying Gatorade's the best one, but some sort of an electrolyte drink when you are truly sweating is good.
And I would say if you're eating a normal diet,
yeah, you're probably getting enough.
That's too much sodium.
And
just drink water. Yeah. But yeah, if you drink Gatorade, that's great, and you probably end up getting diabetes. But at least your kidneys will be. I'm kidding. No, but I think the other thing that I would want to keep a close eye on too is seeing your doctor. We all. Fortunately, knock on wood, you and I were older, but we don't have any of these medical problems yet.
Thankfully, yeah.
And I think by exercising and eating a reasonably balanced diet, you can prevent a lot of these things from happening.
For sure. Genetics plays a big role.
Hypertension, though, is very common. Diabetes, very common. Yep. And monitoring your health metrics can really help to catch these things early. Yep. So you never really damage the kidneys because of your diabetes because it's well controlled, or your hypertension because it's well controlled. Yep. It's really important. You don't want to find out that you should have been managing your blood pressure for 20 years when you didn't, when your kidneys start to fail and your doctor says, well, if you would have started a blood pressure medication a while ago,
you'd have been okay. Right. Now you have to go to a dialysis center 3 times a week for 4 hours at a time. What do you mean, Doc? I got to work. Well, it's either that or die.
Right.
Yeah.
So I think that's something we haven't talked about at all.
That's true.
Actually, I think for us to have kidneys, let's be grateful for those amazing metabolically active renal cells and what they do and all of the wonderful things they do to keep us healthy, and be grateful for that. There are a lot of people in this world that don't have kidney function, who have got to live the life of a dialysis patient, and you talked about it, very difficult. Yeah. And so I think being grateful for healthy kidneys is good too, and maintaining their health, drinking, staying hydrated, and seeing your doctor.
Monsters are not hydration. Sorry.
No. Yeah, you're right though. I mean, caffeine dehydrates.
That's
you.
right. Yes.
There's a lot of dangerous chemicals out there that can actually cause increased kidney damage.
I just had every firefighter that's watching or listening just turned us off and said a bad word. Shut up, ball.
Well, I would say to that point, I know we don't have much time. We're almost done here, but I think in life, enjoying the things you like
It's
to
all
enjoy
about
in moderation is
balance,
fine. Balance.
Yeah, but I mean, if you're drinking 3 Monsters a day, that is not healthy for you in a lot of ways.
Yep. And if you have to have something fizzy, get some sparkling water and integrate that into your what you drink every day.
Yeah.
Ice cold sparkling water could be pretty refreshing. I know it's not as sweet. Obviously, there's no sugar in it, but find a way to get the water into your system. Take care of your kidneys. Be nice
Preventative
to them.
medicine is the best medicine.
That's right.
Not having to deal with it at all is the best way to handle it. Well, it's a good topic, an important topic. I don't think it's talked about quite enough. So I think this was good. Hopefully, I know I learned a lot doing this lecture.
Yeah, I always do. When we research these topics, I learn. I mean, a body part that weighs less than 0.5% of our body, it consumes 10% of all of our oxygen.
Yeah,
that's pretty impressive.
It's crazy.
It's a pretty amazing organ.
Yes.
So we got to keep care of them so they don't fail.
Keep care.
Yeah.
Let's keep care.
Good lecture.
See you on the next one.
Be safe out there.
Thank you for listening to EMS, the Erik and Matt Show.